You can do that using the webinar access. If you are using French interpretations, you can click the world icon. It looks like a globe at the very bottom of your screen, and it will allow you to click or mute the original audio, and then you can manually select in French. We have the ability to communicate with each other using the chat function, and you should see that automatically on your screen. If you don't, it's click under where it says more, and there's 3 dots, and you'll see that it is the chat function here. And I've just welcomed myself. If folks would like to introduce themselves and tell us a little bit about where you're coming from today, please do so in the chat functions. Really happy to have you do that, and we can track questions in that chat as well. Today's presentation is part of a broader series that we are really excited about presenting. And as a part of this summit, we're going to be talking about food security and food insecurity, from the very basics of what that means to where it's most prevalent geographically and amongst certain populations. That's going to be, of course, followed by the impact of and relationship to specific disease groups and diseases, and how that hits people. Right now, how it's hitting people is in the pocketbook as well as in their own health and wellness, because, of course, with the consumer price index skyrocketing and interest rates on the up, we know that food is one of the most expensive items in that consumer price index in the increase. And we know that food insecurity is sometimes being felt for the first time by some people. And this may be additionally true of others with very specific nutritional needs, such as vulnerable populations, older adults, and people with degrees of frailties. I also want to talk a little bit about the impact of the pandemic. We know, of course, that worker shortages are at a high, and so sometimes places that we are expecting to be able to go to are closed. Sometimes the resources that we rely on aren't available to us anymore. And we've had that really insecure feeling for the last 2.5 years. Now, as COVID has offered up some new opportunities around food, including lots and lots of delivery services, that often has additional expenses to it as well. So people are really trying to understand their relationships with food security, economics, inflation, and how that all wraps up with COVID. And like so many other people, my parents couldn't go to the grocery store because they were in an age group that was very high risk. And so again, even regular outings to some of the markets and food stores for people who didn't previously have food insecurity has been challenged by COVID as a disease. I want to just flag again that this webinar and 3 others are in preparation for the Patients Redefining the Future of Healthcare in Canada Summit. We'll tell you a little bit more about that. You can see that on the slides right there in front of you as well. Very exciting for this summit. We are going to have some incredible speakers, including the Federal Minister of Mental Health and Addictions, Carolyn Bennett. We have Sheila Watt-Cloutier, the environmental, cultural, and human rights advocate, and of course, the author of The Right to Be Cold. We're going to have as well Rashida Fernandopoulos, the Chief Innovation Officer for One Medical and also co-founder of the values-based primary care group in Boston, Massachusetts. And she's really focused on providing better quality and lower costs in the development of medical services to everybody, which of course is one of the big drivers that we're all going to be talking about. And we're going to talk about echo pandemics in health for different populations. For those of you who are not as familiar with the term of an echo pandemic, think about your boom, bust, and echo. So we know that as many people have had treatment put off, as supports and services have not been made available, as care or other innovation foci have not been on non-COVID disease states, that this has had a huge impact and has had this knock-on effect to other areas, and certainly food insecurity is, as we're talking about, one of those areas. Let me take just a quick moment to introduce to you our amazing panel, but we're going to also flag for you ahead of time that there will be an evaluation. Everyone wants to know how we're doing and why. So I'm going to remind you at the end as well, but there will be an evaluation that follows up with perhaps some extra materials as well. So at this point, let me just introduce to you the three experts that we have today, and then I will turn it over to them. So we're going to start off with a recording, and this is a really exciting and interesting recording, and it's provided by Dr. Koch, whose current research is focusing on food security, particularly amongst refugees, such a huge issue that we're seeing all over the world, and of course right now at an all-time high in our Russian and Ukrainian areas, but of course, let's not forget the myriad other places in the world where refugees are managing against incredibly difficult times. His work also is on food policy and civil society, thinking about immigration and diasporic foodways here in Toronto. He's looking at all kinds of outlets in Toronto, examining the relationships between ethnic restaurants, immigrant entrepreneurs, and social connections. He's been certainly involved in many national and global debates on these issues, globalization, food security, and peace studies as well. And he's also a very frequent commentator, very specifically on the social change and politics in Turkey. Really looking forward to that. I'm going to take an opportunity to introduce our two other speakers before we also run into the rest of our presentation. So our second speaker will be Dr. Vatanparast, who's a professor with a joint appointment to the College of Pharmacy and Nutrition, as well as the School of Public Health at the University of Saskatchewan. Hassan is actively involved in research and health promotion initiatives, again, often targeting food insecurity and nutritional health statuses. He's focused his work on how that impacts marginalized people. He, of course, is very well known for his work on advisory panels, scientific committees, editorial boards, not just in Canada, but globally as well. So health promotion and research globally, such a key point in what we're going to be talking about with the goal of improving nutritional health, particularly, again, of at-risk populations. And our last speaker is Dr. Lynn McIntyre, Professor Emerita of Community Health Sciences in the Department of Community Health Sciences, also, of course, a member of the O'Brien Institute for Public Health in the Cumming School of Medicine at the University of Calgary, Alberta. She's retired from active faculty position in November 2015, but I have to tell you, she has not stopped at all and is so involved, of course, in research, policy, and advocacy, really focused on household food insecurity with both a medical degree and master's degrees in community health and epidemiology from the University of Toronto. Of course, she is a peer and peerless and has been, of course, added as a fellow to the Royal College of Physicians in Canada in public health and preventive health, as well as a fellow of the Canadian Academy of Health Sciences. Appointed to the Order of Canada in 2020, she was recognized for her influential research in health equity and food security and insecurity, as well as for public health policies in Canada. We have the best of the best of the best, and I'm delighted to open the floor at this time to our first speaker.
I'm sorry that I could not be with you today. The program for this session was set earlier than my teaching schedule. If you have any questions or want to learn more about food security issues, please email me or check the website for our distance learning food security certificate at TMU. In my presentation today, I will provide some basic definitions and insights on extent of food insecurity around the world and in Canada, and provide some preventative measures to reduce it. Food security is an often misunderstood concept. Food and Agriculture Organization of the United Nations defined food security as a condition that all people at all times have physical and economic access to sufficient, safe, and nutritious food to meet their dietary needs and food preferences for an active and healthy life. Based on this definition, people who lack regular access to enough safe and nutritious food for normal growth and development and active and healthy life would be considered as food insecure. At the Center for Studies in Food Security at Toronto Metropolitan University, we use the 5 A's of food security to provide a better description of what this concept means. The first condition for food security will be availability of food. This means having sufficient production capacity, avoiding food loss and food waste, and efficiency of the supply chain in delivering foods. Most people think that we do not have enough food to feed the world population. However, we know we have a lot more than we need, although threats to availability always exist, such as wars or climate change. We do not realize 30% of the food we produce are lost or wasted between field and our tables. These numbers do not even include grains and oilseeds used as animal feed or biofuel. Pimentel points out that more than half the US grain and nearly 40% of world grain is fed to livestock rather than humans. A second A of food security is accessibility. Sadly, a significant portion of the world population cannot get access to sufficient food. In market economies where food is produced as a commodity for profit, people who do not have sufficient income or who have other priorities such as housing, healthcare, and education suffer food insecurity. Third A refers to adequacy. Food security implies provisioning of healthy and safe food to all people and a sustainable and resilient local food system that feeds consumers and provides livelihoods to farmers and others involved in food provisioning. Fourth A refers to acceptability, which means people should be given access to culturally acceptable foods in dignified forms of access. Finally, the fifth A refers to agency. At the basic level, agency refers to individuals and families that oversee what they will eat. However, in modern societies, agency involves institutions and structures as providers, suppliers, enablers of access to food. This includes food producers, distributors, processors, governments, and civil society organizations. In 1996, at the World Food Summit, there was an estimation of 800 million people without enough food, and a commitment was made to reduce hunger by half to 400 million by 2015. Unfortunately, we could not reach this target. Currently, the estimated numbers of undernourished people are around 828 million. Factors such as climate change, natural disasters, pandemics, wars, and economic crises likely to raise the numbers of food insecure people in Canada and around the world in the coming decades. There has been some progress towards achieving food security in different parts of the world. Yet food insecurity remained prevalent in sub-Saharan Africa and Asia among the poorest countries and regions involved in recent armed conflict. However, as these global numbers are based on some mathematical calculations rather than surveys, it is fair to say that global food insecurity numbers are likely to be much higher. Statistics Canada measures food insecurity by using the Household Food Security Survey module, which consists of 18 questions about experiences of food deprivation over the past 12 months. Food insecurity can be experienced in various levels. Marginal food insecurity means worrying about running out of food and or limiting food choices because of insufficient income. Moderate food insecurity means families are compromising the quality and or quantity of their food intake. Severe food insecurity happens when people miss meals, reduce food intake, and or must go without food for days. According to Statistics Canada, in 2021, 15.9% of households in the 10 provinces of Canada were food insecure. This meant 5.8 million Canadians, including 1.4 million children under the age of 18, were living in households that experienced some level of food insecurity. These numbers are considered as underestimation because the Stats Canada survey sample does not include some of the most vulnerable categories such as people living in First Nations reserves, remote northern areas, or homeless people. In Canada, percentage of individuals living in food insecure households was highest among Indigenous peoples, 30.7%, followed by Arabs and West Asians and Blacks. This rate was around 13.2 among people who are not visible minorities. Food insecurity rates were much higher in the territories. In 2020, for example, 46.1% of people in Nunavut lived in moderate or severely food insecure households. We often assume that food insecure people are not working. Data indicates that 1 in 7 people suffering food insecurity were relying on employment income or self-employed. One of the common responses to food insecurity was food charity in the form of food banks. The first food bank in Canada opened in 1981 in Edmonton. Within decades, food banks spread all over the country. In March 2021, there were 2,332 food banks serving to almost 1.4 million people. Hunger Count report gathered by Food Banks Canada collect data every March on the characteristics and numbers of people visiting food banks. The data indicate that 33% of those served by food banks were children. Hunger Count report demonstrates that many of those who are using food banks rely on either some form of social assistance program or job income, indicating insufficiency of household income is the main cause of food insecurity. While providing valuable information, food bank data is also considered an underestimation. A report released by Proof, an interdisciplinary research program at the University of Toronto, demonstrated that only 20.6% of people who are food insecure reported that they would use a food bank when short of money. Food insecurity is a symptom of the failure of national and international institutions and the food system. As social assistance programs declined since the 1980s neoliberal reforms, civil society organizations took the responsibility of assisting the most vulnerable groups. Many of these organizations lacked the legitimate authority of government-run programs and had to operate with limited financial and human resources. As public health experts would remind us, prevention of disease and health promotion saves more lives at a much lower cost than the diagnosis and treatment of diseases. This is true for food insecurity. Successful programs such as Zero Hunger, adopted by Brazil during the early 21st century, proved the most effective results in such a short time. We have enough food to feed the world at present and in the near future. Current mainstream solutions, unfortunately, focus mostly on increasing availability and providing charitable assistance to food insecure people. However, food insecurity needs to be seen as a symptom of systematic failure. At the national level, it reflects the failure of the state in providing the necessities of life to its citizens. At the international level, it shows the consequences of broken promises for development and external debt assistance to less developed countries, collaboration with corrupt and anti-democratic regimes, and not controlling global arms trade. Poverty and armed conflict have created the biggest numbers of food insecurity in recent years. Working for food security is a never-ending objective. Preventative measures to reduce food insecurity may include promoting income security and development assistance policies instead of charitable solutions, reducing food loss and waste, preventing diet-related ill health, supporting local farmers and food workers, working towards a just, sustainable, and resilient food system, and strengthening the international system to prevent wars. We should also remember the interrelated nature of food security with other public priorities such as employment, shelter, education, healthcare, environment, and peace. Those of us working for health, social and environmental justice, peace and democracy should work for multifocal and multi-stakeholder advocacy instead of single-issue focus. Civil society organizations in Canada have been advocating for food security for a long time. Food banks, food policy councils, and community food security organizations have been doing exemplary work. Following the 1996 World Food Summit, Canada adopted an action plan for food security in 1998, but it was forgotten in a few months after its adoption. This indicates that policies that may have potential to bring change mean nothing when they are not implemented effectively. An important recent development is the Canadian Advisory Council on Food Policy in 2021. It has not delivered much so far, but it can be an important instrument in monitoring food security and bringing systemic food policy changes. Thank you.
Good afternoon, everyone. I would like to thank the organizers for inviting me to join you in this event. Today, I'm going to be briefly talking about the association between food insecurity and chronic diseases. But before starting my talk, I would like to acknowledge that I live and work on Treaty 6 territory and the homeland of Métis, and also we pay our respect to the First Nation and Métis ancestors of this place. Also, I'd like to acknowledge that I have no conflict of interest related to this talk. Here is a quick outline of what I'm going to be covering today. First, I'm going to be talking about who are affected by food security, and then I'll go to food security and chronic diseases, how these two are associated, role of diet, and also stress in that. And I will wrap up my talk with talking about food insecurity and COVID-19. If you look at your diagram at the left, this is 2017-18 national survey data on food insecurity. You see that the rate across provinces are different, with having Quebec with the lowest rate and New Brunswick, Nova Scotia with the highest rate. Now, if you go to the territories, you will see that Yukon has the lowest and Nunavut has the highest, with over half of the population dealing with food insecurity. Now, during pandemic in 2021, if you look at the data, you will see that rate of food insecurity has increased significantly all across the board, from British Columbia to Maritimes. Now, in between, one of the major changes is that Alberta had the highest rate of food insecurity, and Quebec still had lowest by 2% increase compared to 2017-18. And in 2021, overall in Canada, if you translate these percentages to numbers, 5.8% of 5.8 million of Canadians had food insecurity. So who are the people who are more at risk of food insecurity? Single mom is one of the main groups, and then we have low-income households and Indigenous people. So for observed Indigenous people during COVID-19 pandemics, up to 30%, 1/3 of them almost, they are dealing with food insecurity. You saw what is happening in territories in the north. They have the highest rate in Canada. The situation is not that much better in ethnic minorities. So this is something that needs to be worked on. Newcomers are also very much at risk. If you look at two national survey data, you see that the rate is very similar to general population, but the challenge is in there is that those who cannot speak in English or French, the two official languages, are excluded from national survey data. If we hire interpreter using the same survey tool, you see that the rate is much higher, over 55%. So this is important to consider that. Household renting, again, is another group of population. Those who do not own their own house are at higher risk of food insecurity. Now, moving to food insecurity and chronic diseases, how these two are related. So if you look at two chronic diseases, chronic conditions lens, you see that most chronic conditions are associated with increased odds of household food insecurity. From food insecurity side, you see that there is association with odds of chronic diseases. It's kind of a two-way relationship between the two. Here are some evidence. Adult food insecures are more prone for chronic diseases. Also, we need to consider that it's not just about physical chronic diseases, it's about mental health issues as well, like depression and suicidal tendencies in children, adolescents, and also in adults. Say those who have food insecurity, they have challenge in managing existing chronic conditions, say by management, for example, regularly purchasing and using their medication. Those who have food insecurity, among them, those with highest, with multiple chronic diseases, they have higher odds of severe food insecurity compared to those without chronic diseases. So most chronic diseases also associated with increased odds of food insecurity, independent to their social demographic characteristics of the household. So these are important things to know. Now, going to research from our lab and also others, we see that there is an association with food insecurity with some early biomarkers that show onset of chronic diseases. There have been many studies done relating the two, food insecurity and chronic diseases. This is one of our studies looking into national survey data from 2007 to 2012. You see the consistency in pattern of association between chronic diseases and food insecurity. For example, irritable bowel disease, almost consistent in all national survey series. And then arthritis as an example of autoimmune disease, you see very consistent all across these surveys. There's association, and diabetes another one. Now the question is that which one comes first? Is this food insecurity or chronic diseases? We all know that food insecurity has a detrimental effect on health. How? Through the impact on diet quality, and also in conjunction with other stressors, mainly life stress. So looking at from the left side of this diagram in here, if you have issues with hampering pillars of food insecurity, food security, in fact, it really affects the choices of food, quantity and quality, and then chronic diseases come in. And then if you look at from chronic diseases perspective, if you have chronic diseases, it may have impact on food choices and quantity and quality, and you enter to food insecurity. So to have a more comprehensive picture, we can bring the role of stress in here. You have food insecure and you have constant stress related to that. Then you come up with coping strategies that decreases the quality of the food that you are taking, and then the quality of food is going down, chronic disease starting showing up. And then when you have chronic disease, you can't function very well. Then employability is affected, cost of care, healthcare expenditure is going to be affected. And then you are spending more while your income is going down, and then enters to that vicious cycle. Now, from diet-specific perspective, you see that we have data that shows that food insecurity is associated with nutritional vulnerability in a way that an unhealthy diet is one in the 3 leading factors, risk factors for chronic diseases. And those who have food insecurity, living in food secure households, they have issues with nutrient inadequacies and reduced intake of fruit and vegetable and milk products as indicator of perhaps high quality and nutrient dense food. There are animal models showing that if you expose them to hunger, it activates preference of high fat and high sugar food. Now, if you are into high fat, high sugar food and lowering the intake of fruit and vegetable and milk products, it's basically you're adopting unhealthy diet and increases the risk of chronic conditions. So looking at this relationship, you see that it perhaps justifies the movements that are happening, that you may have seen that food as medicine or food is medicine, kind of sitting in between nutrition and healthcare in addressing chronic diseases. This is really, there is room for discussion here because we have seen movement in prescribing food as medicine, but how effective it is, this is a question in here. I remember when I was a child, my mom was telling us that eat good food or medicine will be your food. So looking at from that perspective is really preventative measure. But now you have contracted disease and prescribing food, this, and then perhaps in conjunction with medicine, this is something that really explored more. I am not sure about that. I'm hoping that Dr. McIntyre covers that area. Now, what is happening with food security and COVID-19 pandemic? You know better than me that how our food system have been impacted by food insecurity. Even 2 years after that, all of us, we see that the issue with supply chain and cost of food is still the cost of food is significantly high compared to pre-pandemic. Then rate of food insecurity has increased. You saw the data from 2021. Also studies from our lab and also others have shown that healthy dietary pattern with adequate nutrient intake boosts our immune system in combating COVID-19. And then if you move to food insecurity, definitely you won't have healthy dietary pattern. Then comes to those who are really at risk and going to food bank. So for misplacing the slides, going to food bank, the issue with providing service for those who are really at need is another factor that happened during pandemic. Now imagine that during pandemic, the level of anxiety and stress that we all had, and also depression that many people had in conjunction with food insecurity, what's going to happen in terms of impact on chronic diseases. If I wrap up my talk, we already know that there is a vicious cycle between food insecurity and chronic diseases. You see a range of them, like say diabetes, starting from diabetes going to autoimmune diseases. Now we know that food insecurity is a factor or health determinant in the category we call them social determinants of health. Among them, we know that unemployment and job insecurity and income social protection have impact on increasing food insecurity. Now, what happens with COVID-19 pandemic, these two lead to severe COVID-19 outcomes. With this, then the question is that what should be done? What policies are in place? I leave it to Dr. Lynn McIntyre to cover that area. Thank you very much for your attention.
Thanks so much. What a great presentation. And now I'm delighted to introduce Dr. McIntyre to the stage. Dr. McIntyre, over to you.
So I want to thank the organizers, Canadian Psoriasis Network, for inviting me. And I also want to acknowledge I'm speaking to you from Treaty 7 territory in Southern Alberta, which is also the homeland of the Region 3 Métis Nation. So I am hoping to provide some policy direction to inform your summit related to the patients redefining the future of healthcare. So I'm trying to advance my slides here and I'm not getting success. Okay, so what have we heard so far? I think you've heard from Mustafa and Hassan that household food insecurity is highly prevalent, 15.9% of provincial households, and that those that are affected are well described in terms of their socioeconomic grouping and housing configuration. We've also heard that food insecurity is very bad for health, and it's when you're food insecure, it's also bad for your management of your health problems. And then food insecurity is not good for many of the poor outcomes. We've heard a little bit that food insecurity is a food problem, but I hope you got a glimmer from what we heard about food banks as not being a solution, is that food isn't the solution to the problem, nor is the solution to the problem to medicalize it. And again, if we have time in question period, I can talk about some of the food as medicine initiatives that are basically prescribing food for people who don't have enough money to buy food in order to improve their diabetic outcomes, for example. But I thought I would begin with a bit of a thought experiment on health problems and food insecurity in order to help inform your summit. And since I was invited by the Canadian Psoriasis Network, I thought I would just use psoriasis and the psoriatic arthritic, these inflammatory arthritis conditions and other conditions similar, just to give you a picture. And this could apply to many, many conditions. So let's look at psoriasis study, and these are all recent studies. And the outcome is poor quality of life. And what predicts poor quality of life for those with psoriasis is to live in low income, to be women, female, to have lost your employment because of your psoriasis, and not surprisingly, but importantly, lesions that are above the neck. Looking at arthritis, and this is all the broad spectrum of arthritis. And when you look at the outcomes of limited physical activity, limited social activities, joint pain, limited ability to work, there are 5 social risk factors that were examined. Each of them was related to all of those outcomes, including the joint pain, including limited social activities, food insecurity, housing insecurity, financial insecurity, living in an unsafe neighborhood, and having problems in healthcare access. And if you had more than one of these factors, then they started to create a gradient. So you even had more severe outcomes of these 4 types. Another study done during COVID was actually asking rheumatologists what they felt was creating the greatest gap in health among their own patients during COVID. And they said it was the low health literacy of their some of their patients, the patients that were living in poverty, the patients that lived with food insecurity, and those that had improper access or less access to telehealth. They had already said, well known, that there are racial and ethnic minority differences among, and also for those that are living with low socioeconomic status, but this was widened. So one more. So then this is a study that was done on with the outcome being who is food insecure. So it's among populations with mobility impairment and disability. And this study was done in Canada. And I should say there were 2 studies done in the United States, United Kingdom, looking at all types of disabilities and food insecurity. And they found, disability is really bad for food insecurity, and worse disability and multiple disabilities were all really bad. But this was one that actually said, wait a minute, where do people live? And what is food insecurity going to be different in where they live? And in this study, which was relatively recent, 2019, if you lived in my beautiful province of Alberta or in Quebec, and you were disabled with mobility impairment disability, you had a lower risk, significantly lower risk of being food insecure than those that were living in Ontario as a comparator. And they said, well, it's the disability benefits that explain variation. But just look at your right. You've already seen this slide. So this is our most current data on where people live in terms of food insecurity. in the 2021 Canadian Income Survey. And you see my beautiful province of Alberta is the reigning capital of food insecurity in Canada, with Quebec being continuing it's always the lowest rate. 7-point difference is a lot in policy. So I put to you that there is a policy around the assured income for those with severe handicap, which is our disability benefit in Alberta, that is almost a guaranteed livable income level. And that is actually showing its effect, very similar to Quebec, whereas the rest of our policies in the province of Alberta are not doing the same. Now, if this were a class, I'd be able to stop the class and say, what are you thinking with all these different studies? What observations do you make? But we don't have the time for that. So I'll just tell you what are some obvious observations. Bad health outcomes usually have poverty, food insecurity, social disadvantage in the predictor list. And yes, you did see there are problems in healthcare associated with bad health outcomes for vulnerable people. So we saw healthcare access, lack of access to telehealth. But I would put to you on how you study a problem like food insecurity and health matters. Few studies look for evidence of policy disruptors to the usual pattern. What actually could make a difference, like I showed you, the disability benefit levels from one province to another. So if you really want better health outcomes for patients, then you really can't ignore what lies beyond healthcare. But I would like to stress it's equally unwise to medicalize everything that makes people sick. So what are policy interventions to reduce household food insecurity? So we define, and I think it was a little bit alluded to by Hassan, in the use of the Household Food Security Survey module in Canada to monitor food insecurity. The definition is household food insecurity is lack of access to adequate food because of financial constraint. And so that is the first premise. The second premise is that food insecurity occurs as a gradient. And Mustafa alluded to mild, marginal food insecurity, moderate food insecurity, severe food insecurity. Well, these are just three gradients, with severe food insecurity being the most severe, the darkest bar, for poor self-rated health, poor self-rated mental health, and life stress. So that's the common gradients you see in terms of food insecurity and a variety of outcomes. But when it's a gradient, that has really important implications. So this is an if-and statement. If it's related to financial constraint and if food insecurity occurs as a gradient, the intervention should act on the gradient through income. So how do we do that? So tackling that social gradient and creating overall better outcomes. It's a concept of leveling up. And so here's a classic slide. It's Canadian data. It's a bit old, but it's very illustrative. So on the left-hand side, we have life expectancy for men 25 years of age by the income quintile, with one being the lowest income quintile. And you see that a very low income male would live for another 48 years in comparison to a 55-year span. So that's a pretty sharp gradient. The slope is pretty sharp for men. You see at the same time period, the very shallow gradient for women, that while there's a difference, it's actually pretty shallow. But more importantly, the lowest income woman, her life expectancy exceeds the highest income man. Now, this is for life expectancy. This is absolutely the way the gradient works when you do leveling up. And that's what we're proposing as the most important thing for the 5.8 million plus that are actually living in food insecurity in Canada. So it's all about income. So this is the sources of income that people report and their level of food insecurity. So if you have received social assistance in Canada, do not pass go directly to food insecurity, with over 63% of recipients reporting food insecurity. But disturbingly, about half of that group is severely food insecure, which has the worst implications for health and the most for misery and stress. We see the COVID benefits and the employment insurance was still high, probably not generous enough to stave off food insecurity. And then we see towards the bottom, we see those on wages being relatively low, and seniors' public pensions, which has been really quite a topic. So these are individuals who live entirely as a main source of income from the guaranteed income supplement and the old age security. And they're doing about as well in terms of food insecurity as those who have wages. And why is that? So these are, so we have three lines here. The blue line is the poverty line. It's way, way, way up there compared to the bars, which are what social assistance rates are in the provinces. And while these data are about 10 years old, there's no change in the kind of pictorial effect that this has. And then the old age security guaranteed income supplement in that year was $16,250. So you see that the individuals can remain food secure despite being below the poverty line because of the assured income, but it's much, much, much higher than social assistance. And so the old age security guaranteed income supplement is one of our examples of basic income or guaranteed annual income. So this study has been well reported. And it basically shows what happens when you have basic income. So we have individuals age 55 to 65, they're unattached, they're low income, and their food insecurity rate measured by our Canadian Community Health Survey was 27% on the whole. Magically, they turn 65, they get a birthday cake, and their variety of income sources from the past turn into guaranteed income supplement, old age security. And they drop from ages 65 to 75 to 11% food insecurity. So that's over 50% food insecurity rate drop with a single policy intervention. And I guess we would all submit that there are very few policy interventions that are so potent as this, which is why there have been such proponents for the guaranteed income for Canadians. We have similar studies, not as dramatic in terms of the child benefit, and we're starting to see in some of the disability benefits with a guaranteed income, again, similar good results. So a basic income is really what food insecurity advocates who understand that it's about financial constraint, that it is really an important intervention. It ensures everyone an income sufficient to meet their basic needs, living with dignity regardless of work status. It is the way to level up our insecurity gradient. So I guess I'd end with my policy advice for the summit. If you really want better health outcomes for patients, then you cannot ignore what lies beyond healthcare. It's equally unwise to medicalize everything that makes people sick. When you're redefining the future of healthcare at the summit, keep a look out the window so that you do not forget that income-related changes would make a real difference to people's health. So I look forward to your questions and thanks for your time.
Thanks so much, Dr. McIntyre. And I'll get you to just stay on screen and we get to have a little bit of a conversation as well. We've already had lots of questions come in, and I encourage more people to put questions in the chat box. But I wonder if I could just pick up first on that medicalizing piece as well. So we've talked about, the social prescribing, which many people will know is gaining real traction, I think, in the idea that you can go to your doctor, or these days, primary healthcare provider, increasingly at this point, and instead of a prescription for, let's call it hydromorphone, you might get a prescription to go to the museum. And that's a very stark example, but we're seeing more and more opportunities to literally get a prescription and then it can be covered by governmental healthcare plans. Can you speak a little bit more about, the food prescribing as an idea, and is anyone doing it?
Yes, thanks for that. So the principle, as I mentioned, is that because you can't afford healthy food, then that's what the medicine that you need in order to improve the management of your chronic disease. So the studies are populated through Australia, the United States. They're ongoing in Canada. And so let's be clear that if you prescribe, and that means you give, that means and the last study that we looked at was extraordinarily generous. So basically it was 7 days a week, almost full replacement of the diet for the entire household, for 6 weeks. And so then they showed that people ate the food, and that in fact among the diabetic patients that were the target, they had some improvement in their blood sugar control, and it was too soon for weight and other things, but it looked very positive. So these are spurring more and more of these types of studies to actually give a healthy diet to someone. So my colleague Valerie Tarasik, we've heard about proof today a lot. You've seen a lot of, so she and I were the founders of the proof study. So we just published this week or last week a reconsideration of the Food as Medicine program. And what we raised is the very serious issue of sustainability. This is not a sustainable measure. This is in fact has nothing to do with root cause. That at most, how would a hypothesis read that you wouldn't even eat these foods, right? So we already know from many studies that low income people with chronic health conditions, they know exactly what they're supposed to eat. They don't need to be taught, they just can't afford it. It also creates a sense of who's deserving. So I think that Hassan was very helpful in showing mental health is very seriously affected by food insecurity. I was showing you psoriasis is affected, arthritis is affected, but it's really the diet sensitive conditions that get privileged here. So you run after your diabetics, you can run after some people that require gluten-free. And so you're starting to see like who's deserving, who's not deserving. And then when do you get kicked out of such a program? You go back to your miserable life. So, these are not affordable, not sustainable. They medicalize for somebody's outcome that the person who's got diabetes has a lot in living in poverty, has a lot of outcomes that are important to them. Whether or not they satisfy their physician with the A1C may not be their priority. So we really think that this needs to be rethought, and we need to reshift on what are the entitlements. So I'll just finish up. There are ways of looking for what they call a poverty screen when you go to see your physician. So they are sensitive. When they prescribe something that's a generic as opposed to, a brand name, that they consider whether or not you're able to fulfill these things. You can also be referred to your entitlements. We know that many people are under adopting the entitlements they have from benefits that come from the state or things they can apply for. Giving somebody a referral to a food bank is really not it, but there are really appropriate things that can be done by recognizing people's poverty state when doing good medical care without resorting to these, going down to to get a hamper from the food cache that's attached to the institution. I think you might actually be talking about this at your summit, because I think it's
actually
quite important.
Yeah. Summit. Yeah, I really want to thank you particularly for the reminding of that importance of that guaranteed flow of income. It's like not a one and done kind of thing. Here, I give you $500, everything's going to be fine now. It's that policy regularity and how that allows people to plan as well, and allows that guaranteed sourcing to come through. Dr. McIntyre, thank you so much for your talk today. Just an inspiring conversation. I learned so much. We're going to be sharing your slides as well on the summit. And I think you've really kicked off for us how important it is to both look at the differentiated models of who these things are affecting and which are those intervention pieces that can make the most difference. Seeing that 50% driver, I think, holds everybody to account. It's not just a moral good. It is a huge lift out of poverty. It's a lift out of an unwell state. And I really also take your point that when we're thinking about not overly medicalizing everything, but to understand that intersection for well-being. Thank you so much, Dr. McIntyre. I really appreciate it. With this, we're going to wrap up this session, and I'll invite a little bit of information on the closing slides just to remind people that they can start registering now for some of the other echo pandemics, the way forward on November the 14th from 12 to 4. Echo pandemics, the way forward on Indigenous health, November 16, 12 to 3:30 Eastern times. The echo pandemics looking at paving the way to value and beyond resiliency to anti-fragility, November 17th, 12 to 3:30. And then, of course, the patient planning session, which is restricted to patients, caregivers, and patient and caregiver representatives as well on November the 18th. A rich conversation from 12 to 1:20 Eastern. As always, there will be an evaluation that comes off with the slides. Any questions that you have for the first two presenters will be posted on the website. And with that, I'm delighted to wrap it up and invite you to participate in the next great sessions. Thanks, everyone, and we'll see you at the next parts of the summit.